may be manifested through social withdrawal, substance abuse, and even television viewing. However, fight or flight is not always an optimal strategy in modern life. In human, the freeze response doesn't refer to being motionless. The energy mobilized by the perceived threat gets locked into the mind when we go into a freeze. The freeze response is not easily resolved because the locked energy is imprisoned by fear and the trauma. In some instances, we may not even realize that we went into a freeze. When the nervous system has not yet discharged the energy that was mobilized for fight or flight, which results in a blocked emotional energy that could turn into physical pain. Tension myositis syndrome is described as psychosomatic musculoskeletal and nervous symptoms. TMS symptoms include pain, stiffness, weakness, tingling, and numbness. TMS symptoms can occur most notably in the back and other parts of the body, in the neck and shoulder. These symptoms have a tendency to move from one place to another. It is an important indicator that the pain is from TMS. Tension myositis syndrome symptoms are believed to be initiated by fear or anger. The feelings that trigger the TMS symptoms are not conscious. However, symptoms serve a purpose. It works as a distraction to hide the emotional pain. One who suffers TMS believes that it is easier to deal with the physical pain than the emotional pain. Pain response. The pain is auto-response to what we perceive as a danger in physical and emotional aspect. The emotional aspect of pain is derived from fear and anxiety. Also, fear and anxiety feeds the pain and tend to make the pain worse. Pain response is subjective to an individual. Perception and reaction to pain stimulus varies according to the physiological and psychological makeup of an individual. Psychological factors may include anxiety, expectation, circumstance, environment, and cultural background. Pain receptor, nociceptor. Nociception is defined as the neural processes of encoding and processing noxious stimuli that have the potential to damage tissue. This activity is initiated by nociceptors, also called sensory receptors or pain receptors, that can detect mechanical, thermal, or chemical changes above a set threshold. Once stimulated, a receptor transmits a signal along the spinal cord to the brain. Nociception triggers a variety of autonomic responses and may also result in a subjective experience of pain. Nociception can also cause autonomic responses without reaching consciousness to cause pale face, sweating, rapid heartbeat, hypertension, lightheadedness, nausea, and fainting. Modulation of pain. The pain response system involves a set of ascending pathways that convey nociceptive information from peripheral nociceptors to higher levels of the central nervous system, as well as descending pathways that modulates that information. The ascending and descending pain modulation pathway involves many different parts of the central nervous system, such as peripheral pain receptor, spinal cord, brainstem, limbic system, and cerebral cortex. Pain pathways. Fast pain, such as sharp, acute pain, travels through type A delta fibers and neospinothalamic tract. Slow pain, described as an aching, throbbing, or burning pain, is transmitted through type C delta fibers and paliospinothalamic tract. Pain signal continues to travel through the brainstem, limbic system, and the cerebral cortex, and it is modulated to pain response. The limbic system and the prefrontal cortex are the most important pain modulation areas in the brain. The limbic system is a complex connection of brain regions deep within the brain. Generally speaking, the limbic system is considered our primitive brain and is responsible for things like emotion, instinct, basic drives, motivation, mood, pleasure, and pain. It includes the hippocampus, thalamus, hypothalamus, amygdala, olfactory cortex, and cingulate gyrus. Prefrontal cortex is the most recently evolved part of the brain. It occupies the front third of the brain and is involved in executive and cognitive function, such as planning, reasoning, and problem solving, impulse control, and expression of emotion. It interacts with the limbic system for modulation of pain. Limbic system is illustrated in this detailed picture. Modulation of pain. The gate control theory of pain postulates that pain is gated by non-nociception stimuli such as vibration. Thus, rubbing a bumped knee seems to relieve pain by preventing its transmission to the brain. Pain is also gated by signals that descend from the brain to the spinal cord to suppress incoming pain information, or, in other cases, to enhance pain information. Negative emotions such as fear, anxiety, depression, and trauma activate pain excitatory response in the limbic system. When the pain excitatory system gets overloaded, it outperforms pain inhibitory response, which is controlled by the prefrontal cortex. Often, overloaded pain response expands to the motor area in the frontal lobe or the somatosensory area in the parietal lobe. This may result in the illusion of physical pain at the site where there is no organic abnormality. This type of pain is described as psychosomatic pain. This picture illustrates how the sensory function of the body is mapped on the parietal lobe. Pain memory. An individual's pain experience after the first onset of acute injury may linger pain responses for months or years afterward. Protein kinase M-zeta is the engine of memory special molecule. PKM-zeta helps to restore memories in our brains, and it sensitizes neurons in our spines, especially in the dorsal horn, after a painful experience. It's also behind the lingering pain we feel after an injury. It was discovered in the Sector lab with Dr. Todd Sector and Dr. Andrew Fenton. This has to be one of the most surprising discoveries of modern brain science. Here are examples of pain disorder associated with pain memory: chronic pain, spontaneous pain, neuropathic pain, reflex sympathetic dystrophy syndrome, RSDS, neuralgia, trigeminal neuralgia, and post-hepatic neuralgia, and phantom pain. Surgical procedures such as severing the peripheral nerve may not stop pain memory-related pain disorder. Treatment of pain. When the pain is caused by injury or disease, treating the cause successfully will eventually resolve the pain. During the normal course of recovery, accompanying pain can be